Hello and welcome to this training video on obsessive compulsive disorders. I'm Mark Brennan and I'm Project Director for Continuing Education Television, CETV, at the Missouri Institute of Mental Health in St. Louis, Missouri. And with me today is Gary Mitchell, who is a licensed clinical social worker who specializes in treatment of children and adults with anxiety disorder and other related problems. He is the Assistant Director of the Anxiety Disorder Center at St. Louis Behavioral Medicine Institute, which specializes in the treatment of refractory and complicated cases. Mr. Mitchell also is an adjunct assistant professor at St. Louis University School of Social Services, where he teaches cognitive behavioral family therapy. Hi, Gary. I appreciate you coming in today.
Hi, thank you.
I think a good place for us to start in understanding obsessive-compulsive disorder is for you to tell us about some of the basic characteristics of the disorder and some of the diagnostic criteria that would help us to understand how you diagnose that disorder.
Sure. Obsessive-compulsive disorder, also called OCD, is characterized by obsessions and compulsions. Obsessions are thoughts or feelings or urges or images that result in great discomfort. And the compulsions are the strategies the person engages in order to neutralize the discomfort associated with the obsessions. So a compulsion could be an actual behavior that I engage in. The classic example is a person with contamination fears who feels that they're somehow contaminated and then washes their hands until that feeling of contamination goes away. There are also a category of compulsions that are a little more difficult to address and more difficult to identify, that we identify as mental compulsions or mental rituals. And there's a number of them that we'll be talking about later, but essentially they're cognitive strategies, they're mental strategies that people use in order to try to undo that feeling associated with the obsession.
Okay.
There are people who are sometimes identified as quote-unquote pure obsessionals. And many clinicians, when they're diagnosing and assessing, miss the mental rituals. They don't get that part and perceive that the patient is not ritualizing. It's not to say that a pure obsessional doesn't exist, but I haven't met one yet.
Okay.
In order to qualify for the diagnosis, the person must spend at least an hour a day in either some sort of ritual, either mental or behavioral, or the obsessions. It must cause great distress, and or it must cause significant problems in their life.
So those three areas are pretty much standard in diagnosing someone with obsessive-compulsive disorder?
Correct.
Okay.
Correct.
So what percentage of population has OCD?
The DSM-4 indicates that it's anywhere between 2 and 2.5% of the population at some point in their life will have OCD. And when I'm working with, particularly with kids who perceive they're the only one, we'll talk about the number of people in the St. Louis and surrounding area, say 1.5, or I'll stretch it and say 2 million. And then I'll suggest, imagine Busch Stadium filled with 40,000 people.
Oh, yeah.
And that's how many people in St. Louis at some point, in the St. Louis and surrounding area, would have obsessive-compulsive disorder.
That's a lot of people.
That's a lot of people.
Let me ask you, you had just mentioned children. What's the earliest age that you would see a child demonstrating those kinds of behaviors?
There are children as young as 4 or 5 who come into our clinic. I don't treat children that young. I do have colleagues who do. Diagnostically, it's difficult because classically they would not have the kind of specific obsessions you would see in an older person. And what you see more is ritualized behavior that appears to be an attempt to undo some negative feeling, some difficult feeling. And in those cases, it's much more difficult diagnostically, and our approach is much more behavioral. Generally speaking, when we're talking about a clearly identifiable obsession, we have children as young as 8 or 9.
Gosh, that's pretty young.
That's young.
So let's talk about how OCD is manifested in people's behaviors.
Behaviors if we think about the way that OCD affects people, remember that their motivation is to decrease the discomfort associated with the obsession.
Mm-hmm.
So what they might do is purely avoid.
Okay.
And we see many people who get to the point where they can no longer work, sometimes can no longer leave their home.
Mm-hmm.
So they're not necessarily engaging in active rituals, active undoing of the obsession. They're just trying to stay away from triggers that would make that obsession occur.
For instance, if I had a fear of dogs, maybe I would not want to be around areas where there are dogs. Is that
Correct.
kind of the avoidance that you're
Correct.
talking about?
It's more passive avoidance.
Okay.
And if people with OCD sometimes get to the point where they rarely leave their bed, they don't shower, they don't leave the home,
Mm-hmm.
and we're talking now about more passive avoidance.
Okay.
You would see a lot of active avoidance also, which is what we call compulsions, and that would be the classic either checking or watching or repeating, or there's a great number of behavioral types of rituals that people would engage in.
Mm-hmm.
If I'm afraid of contamination, I'm likely to wash. I'm likely to be hypervigilant to the possibility of contamination.
Mm-hmm.
If I'm afraid of harm, being responsible for harm coming to other people, I'm likely to check and make sure the stove is off and make sure the appliances are unplugged and make sure that the doors are locked.
Mm-hmm.
If I'm fearful that I'm going to make a mistake, I'm likely to read and reread. I'm likely to write and rewrite, and teachers will often see this in the classroom. There are other forms of OCD called obsessional slowness, where the person takes a tremendous amount of time to engage in any activity. Just getting up from my chair and walking across the room could take an hour.
Oh, my.
It can be debilitating.
Mm-hmm.
So you see a broad range of behaviors
Mm-hmm.
in OCD, and the important thing is to have a functional analysis to understand what is that behavior or response to.
Well, in all the examples that you give, it suggests to me that there is, at least in the mind of the person who's doing these behaviors, a consistent approach. I mean, there's a reason why they're doing these things, a connection between the behavior and what they're worried about.
Correct.
So that doesn't necessarily, just because they do those things, it doesn't necessarily make them ill. It's the frequency with which they do them and how it affects their life.
Correct. I suppose what you're talking about is the difference between a quirk and a disorder.
Yeah. For instance, like and maybe you've done this too, and I think I know for certain I have. There are times when I have an appointment in the morning and I set the alarm and I go to bed and I turn out the lights. And I can remember thinking that I needed to set the alarm, but I have to check the alarm to make sure that I set it.
Mm-hmm.
That's similar in some ways to what an obsessive compulsive person might experience briefly.
Briefly.
Right?
Right. Or did I lock the door? I
Right.
go back. Or if I leave and I'm in a hurry and a little stressed, did that garage door close?
Exactly.
Yes, but with OCD, what would happen is I would drive back, check the garage door, turn around, leave, be affected by the doubt again, turn around, and check and check and check and check.
Okay.
And there are literally people who take hours to get out of the home because they're checking.
Oh, my.
Yeah.
So there are differences in the behaviors that people manifest depending on the type of OCD that they have.
Oh, sure.
Okay. What are the treatments for OCD?
Treatments, generally, the well-researched treatments fall into two categories. One is psychotropic medication,
Mm-hmm.
and generally the SSRIs, the serotonergic reuptake inhibitors, are the main class of medications that seem to be helpful with OCD.
Mm-hmm.
In our clinic, often people, by the time they get to us, have been through almost every medication that is available
Mm-hmm.
in therapeutic doses and have either no or some relief from the medication. The other well-researched approach to treatment of OCD is a cognitive behavioral intervention called exposure and response prevention.
Mm-hmm.
And essentially, we would help a person to identify what their fears are. We would then set up a hierarchy of situations to help them face, to help them engage in. in order to face their fears from less difficult to more, and would also help them to very clearly identify the avoidant strategies, the rituals and avoidances they're engaging in, and help them to discontinue those.
Okay.
So the exposure is facing your fear.
Mm-hmm.
The ritual prevention or response prevention is discontinuing the rituals while you're facing your fear.
Okay.
And there are other strategies that we use to help prepare people to get to that point.
Mm-hmm.
But the real therapy, the therapy that will ultimately help people get better, is that behavioral component, the exposure and response prevention.
Now, when you do that, do you do that only in theory? Like, for instance, if I had a particular fear of contamination, would you talk me through these steps and help me to imagine doing these things, or would we actually do something physical that would help me alleviate the fears?
Depending on the situation, everybody's different. We would do both or either.
Okay.
There are when it's possible to do the in vivo exposure, to actually do it.
Mm-hmm.
Ultimately, we want to help people do it.
Okay.
But there are times when it's important to do what we call imaginal exposure. And sometimes that's in preparation. People are so anxious that they can't even go close to the actual situation. Mm-hmm. So we help them to do the exposure and imagination at first. Mm-hmm. There are other times when there's no way we're going to be able to really do what the person fears. It wouldn't be prudent. If I fear that there's blood on particular surfaces, we are not going to put blood on surfaces.
Okay.
What we will do is help them to touch surfaces that other people touch normally and deal with their fear and help them to try to disengage from having certainty. Mm-hmm. So to learn to deal with the doubt by allowing it to be until it dissipates. Mm-hmm. But we might have them in their imagination imagine touching blood and imagine doing those things and help them do that until the anxiety begins to dissipate, until they have a sense that this is not really happening. Mm-hmm. And if it were to happen, that the catastrophic beliefs I have about it are probably even worse than the situation would actually be.
Mm-hmm. It sounds like what you've been talking about is that it's important to go slowly with the individual after a thorough assessment to figure out how to help that person deal with the anxiety around whatever they're perceiving to be a difficulty.
Absolutely.
And obviously you're talking about treating people in an outpatient setting, but what are alternatives for individuals who need a higher level of care? Where would they go?
There are only a few places in the country. We have at our institute an intensive treatment program, mm-hmm. but not residential. So we do have people who come from across the country for specialized treatment for obsessive compulsive disorder. Mm-hmm. Once they need a higher level of care than that, say residential treatment, there are only a few places that really have the specialty to provide that. There's Menninger's Clinic in Houston. Mm-hmm. There's the McLean OCD Institute in Boston, connected with Harvard. There's Rogers Memorial in Wisconsin, and a program at UCLA. Mm. There are knowledgeable providers across the country. Not enough, not nearly enough. Mm-hmm. But there are providers who are quite knowledgeable, who often get to the point where just outpatient therapy is not enough, and they need to refer that person for more intense therapy.
Percentage of your caseload, what would be the percentage of individuals that you might refer to one of those programs?
Well, the only time we would refer to one of the other programs is if the person with us needs residential. Mm-hmm. If we can provide up to 6 hours a day of intensive therapy.
Oh, okay.
And sometimes what happens is they may do good therapy with us, but say go home and get stuck in the shower and not be able to come back. And if they're not able to attend therapy, we can't help them.
Sure.
So it's fewer people who we would refer to another program simply because we tend to screen them out before they get to us. Mm-hmm. It happens from time to time. Mm. The bulk of the cases of obsessive compulsive disorder do not need intensive therapy, but our population is skewed because people come to us for specialized treatment. So we see more people who need it than the average clinician.
When we were talking about obsessive compulsive disorder, you're talking about treatment strategies. You had mentioned medication
Yes.
and cognitive behavioral interventions of various sundry kinds. I'm curious, though, about the system that the individual is in, for instance, their family. How does OCD affect family?
It's a great question. We could spend an hour on it, but I'll try to be brief. The family is gradually and significantly brought in to the disorder. And it often happens subtly where, say, as an example, parents with the child feels anxious about certain things, so the parents compensate. They accommodate. And as they do so, of course, the child becomes more anxious because they're avoiding more, which leads them to fear even more. And the system becomes more and more dependent on the parents accommodating for the child. Then often what we see is because of the impact on the family, how much the family has to change their lives. Family members come in the house and the child says, "You can't come in until you wash your hands." Then the child is saying, "You have to go direct to the shower and shower before we can do anything." And the parents will gradually accommodate. Then they start to get angry appropriately, but unfortunately they express it in unhealthy ways. And they often flip back and forth between this pattern of accommodation and then anger and then guilt over being angry and back to accommodation, which becomes part of the problem. So the families often have, you can see depression in the family that's clearly connected with what they're living through. Tremendous amount of anger, sometimes even escalating to violence because the system just becomes so stressed.
I guess they're pretty frustrated by the behavior.
Oh, yeah.
Do you involve the family at all in the treatment end of dealing with the OCD person?
Yes.
Like, would they come into your clinic while you're doing some of this desensitizing of the fear?
We sometimes involve, particularly with kids, we sometimes involve the parents in the actual exposure therapy, although that's tricky because parents are, even if they were mental health professionals, they're still parents.
Sure.
And it's hard to be a therapist with your kid. We include them more often in the individual therapy, helping to negotiate rules and how will you interact and when will you begin to discontinue doing certain things and setting up reinforcement strategies.
So is that tell us about how families can be supportive of their children's efforts or your efforts at therapeutic approaches?
When the child is in therapy now?
Yes.
Well, if the child's in therapy, particularly if it's a child or an adolescent living with the parents need to be included in at least part of that therapy. There are the rare occasion when the child will come to me and say, "I don't want my parents involved. I really want to get better. And as long as they are doing the therapy and we don't have to have the parents involved, I'm okay with it." But it's rare. So generally speaking, we want the parents to understand what we're doing, to negotiate, and for us all to work together, and for the child or adolescent to understand that parents will begin at a certain point to discontinue the accommodation that they were doing. It will be on a schedule, and the child or adolescent will be able to help negotiate that as long as they're in therapy. Yeah.
How does a family deal with a client who's treatment resistant?
That's more difficult, and it's often painful for the family and for the clinicians working with them. But if we have a OCD sufferer who's either not admitting a problem or saying that they are not going to get help, then we strongly encourage, and that's even an understatement, the family members to get help for themselves. And what we want to help the family members to do is to disengage from the power struggle, to disengage from the accommodation, and to normalize their lives in order to help the sufferer really experience life without being accommodated, and life without the flip side of that coin, without being told just to pull yourself up by your bootstraps, because you can't.
Sure.
And at times, that will help the sufferer then be more incented to admit a problem and engage in therapy. If the sufferer doesn't, though, at least it will help the parents to, as best they can, normalize their lives. There are times when the parents might make the agreement not to challenge their child, not to set limits, even an adult child. And it's our job then just to make sure that their eyes are wide open of what the results of that may be, including perhaps planning for the future when the parents ultimately die.
Sure.
If we have a child or an adult child who's disabled, how will they be taken care of? But to help the parents really make clear decisions and to look accurately at what the consequences of their decisions are.
Okay. And finally, we've just got a minute here. What community resources exist for people who have OCD?
Many and not enough. ObsessiveCompulsiveFoundation.org, OCFoundation.org, O-R-G, is a great resource. They have a list of referral sources. Locally here in St. Louis, we have an OCD support group. We have Obsessive Compulsive Anonymous. We have a number of clinicians who are trained in treatment. So there are some good resources, but not clearly enough.
And some final thoughts about OCD that the audience would need to know about?
I suppose the most important message is there is help. People can get better. The treatment is not easy, but what I often say to sufferers is you're going to feel bad if you do treatment or if you don't. And the question really is, are you going to feel bad getting better, or are you going to feel bad staying stuck? But there is help. People can get better.
Well, thanks, Gary. I appreciate you coming in with us and sharing with us your expertise on OCD. I would encourage everyone out in the audience to review the key concepts prior to taking the test. If you do that and look at the glossary, you won't have any problem succeeding. Thank you.